Yeah, thank you for that introduction. I'd like to thank Philippe and all the organisers for inviting me here. I particularly like the last talk on Pancreas Cancer Network. Really good top talk. And I'd also like to thank all the previous speakers because they really set up an introduction for me for this talk here. So just a few standard disclosures. Pancreas cancer survival is improving. It's not a disaster. We're slowly getting better. So 5-year survival rates have gone from 2.5% to 8.2%, but obviously we're still bottom of the league. So we do need to all work together a lot harder. Now, where are these improvements coming from? Well, better surgery, better chemotherapy. Locally advanced cancers, better surgery, better neoadjuvant chemotherapy, and in the metastatic setting, it's still from combination chemotherapy. So I'm going to focus this talk on resectable, borderline, and unresectable cancers. And it's going to be evidence-based, okay? Obviously, I have my opinions, but this is going to be an evidence-based presentation. So this is a good starting point. These are data from the Yorkshire region of England, about the size of Norway. These are data from the 80s and 90s, very typical of what was happening around the world there. And in the blue line, you can see these are patients who've had a pancreatic resection. And their median survival is only 9 months. So clearly a situation like this says, why are you bothering to treat pancreas cancer? So this is the best trial the United States has ever produced on pancreatic ductal adenocarcinoma. 43 patients. But it was intelligent and well designed, R0. And they showed an improvement in median survival from 11 months to 20 months. They were all R0, and they struggled. It took 8 years. So we formed in Europe, we formed an organization called ESPAC, the European Study Group for Pancreatic Cancer, and we liked what GITSIC done, but we weren't sure exactly what was going on because they used multimodality therapy. So we asked the question, is adjuvant therapy any good? So you've got to have a control, i.e. no adjuvant therapy. Chemotherapy, yes, no. Chemoradiotherapy, yes, no. Or throw in the combination. And to cut a very long story short, the core of the ESPAC 1 was this randomized 2x2 factorial design. You've heard Alice Way from the Memorial Sloan Kettering criticizing a 2x2 factorial design. Well, I'm really sorry, but RTOG 0804 also uses a 2x2 factorial design, and that's based in the United States of America. Anyway, ESPAC 1 showed chemotherapy is very good with surgery, but chemoradiotherapy is not so good. So we then went on to compare gemcitabine with 5-FU. All the Americans said, 5-FU doesn't work in pancreas cancer, what a waste of time. So we compared it with gemcitabine, 1,100 patients, absolutely no difference in median survival, 24 months. And this median survival of 24 months is far superior to any median survival rates produced by any radiotherapy trial in the United States or anywhere else. So the next question was, can we synergize 5-FU with gemcitabine? Obvious question, the answer is yes, it kills DNA better. And at the end of the day, you need to appreciate that all these molecular therapies and other approaches that people are taking, at the end of the day, it's about killing DNA. That's what matters. And that's why cytotoxic chemotherapy is still the best treatment for pancreas cancer. So this is ESPAC 4, and again, a big endeavor, 730 patients. You can randomize. It's not an issue if you're committed to good clinical science. And I'd like to point out to you that these are all comers. We're not selecting. This isn't PRODIG. This is not a French-Canadian study. This is not an American study. This is a European study. We take everyone. No selection. And with no selection, you see, you get these really quite good, as Professor Buchler would say, 40%, 40% median survival, months, 40% 5-year survival rate. And for R0, you're getting that 50% 5-year survival rate. Now, this is the PREDICT trial. This is the French-Canadian trial. Fantastic trial. Everyone's mentioning it. FOLFIRINOX is quite toxic, but you can do it. The patients are, however, very, very selective. And what is the reason they've done so well? Well, one is selection. Everyone with a CA19-9 of more than 90 was excluded, so you already got your best patients. And also, as soon as there was even a smell of recurrence, you got more chemotherapy. So you can see here that 63%, 75% of patients continue to have more chemotherapy as soon as there was any sign of relapse. More chemotherapy. And you can see it here. So this is the FOLFIRINOX trial, a Japanese trial. This is the ESPAC trial. And you can see the R1 status, ESPAC 4, 60%, N1, 80%, CA19-9 normal, 62%, the lowest. These are the highest. So these are very, very different eligibility criteria that are being used. And at the end of the day, there's probably isn't a lot of difference between FOLFIRINOX and GEMCAP, and something which seems to have escaped the knowledge of all the previous 4 clinical academics who've spoken. I would like to mention this Japanese trial. This uses something called S1. This is basically 5-fluorouracil given as a prodrug with 2 additional agents which modify gastrointestinal toxicity, i.e. less diarrhea and so on, and also enhances the metabolism of 5-FU from its prodrug in the liver and also within the cancer. So this is a clever way of delivering more 5-FU into the cancer cell, but with less toxicity. There are some pharmacogenomic issues, though, in Europeans have a different pharmacogenomic makeup from Asians, and we don't tolerate it particularly well. But even so, this is 5-FU, which the Americans say does not work in pancreas cancer, producing a 45% 5-year survival rate. This is 5-FU in the right kind of patients. And this is gemcitabine here, 25 months. So this is S1, just bear that in mind, 45%. Surgery, adjuvant, S1. This is the ESPAC trial. This is the Abraxane, nab-paclitaxel. It is a negative trial. It does not work. The FDA does not approve it. And yet I continue to hear Americans say we should give Abraxane as adjuvant treatment. It's not approved. It doesn't work. Why do you want to give treatments that don't work? Now, one of the key issues that we wanted to know was how many cycles you would give. 1, 2, 3, 4, 5, 6 months. If for FOLFIRINOX, that would be 12 cycles. For GEM or GEMCAP, that would be 6 cycles. The answer is you give 6 cycles, not 5 or 4 or 3 or 2 or 1. So therefore, you wait until the patient is sufficiently fit and healthy to have all 6 cycles. You go in too soon, you don't complete the cycles. I've heard Peter Allen say, oh, we shouldn't think too much about adjuvant therapy because patients who get complications after a pancreatoduodenectomy get complications, they don't have treatment. It's nonsense. You know, complications post-Whipples do not affect the giving of adjuvant therapy for the main and does not affect long-term outcome. So one of the key aspects of ESPAC 3 was to examine the role of margins. We hear a lot about margins. We examined all 7 margins in the ESPAC 3 trial. Remember, this is a trial of 1,100 patients. And we were able to establish that R1 within 1 millimeter is different from R0, and that R0 should be greater than 1 millimeter. And this has now actually been adopted in the AJCC 8th edition, which we're all very pleased to see. So yes, trying to achieve an R0 or R1 is important. Now, if you're going to use an R1 definition of at margin, that's clearly going to be different from an R1 definition greater than 1 millimeter or within 1 millimeter. So you have to be careful when you listen to some of these presentations. We also hear a lot about local recurrence. Give radiotherapy, it stops you getting local recurrence. Doesn't make any difference to survival. And these are very, very important data, which went into JAMA surgery. Has already got 1 million hits. So basically, what we did in ESPAC for was to look at when patients got recurrence. And there was absolutely no difference between when patients got local recurrence and survival after recurrence compared to distant recurrence. In other words, whether you get local recurrence doesn't matter. What matters is whether you die or not. And actually, if you look at the curve here, which is local versus distant, the red is actually, well, it doesn't matter. There's no significant difference between those two. And if you get lung mets, which is the black here, you actually live a lot longer than if you get liver mets. And we used to think the opposite. We used to think, oh, lung is terrible. Actually, if you get lung metastasis, your median survival is 33 months. So worth treating. So this is what's happened with ESPAC, and I noticed that not a single surgeon who spoke this morning from the United States shores of America mentioned ESPAC. And yet it's the key organization that established the pivotal trials around which we base our current practice. I don't know why. No chemotherapy, 8% 5-year survival rate, and you go right up to the combination GEM-CAP, 28.8% median, 5-year survival rate. All comers, all comers. What does this mean? Well, this is what it means. These people are alive today around the world who would otherwise be dead. And these are trials of nearly 3,000 patients. And what we show in these ESPAC trials is consistency. In other words, we're able to repeat and reproduce the previous findings. And this is what's happened. So this is a simple idea. Give really good surgery and then give really good chemotherapy and give as much of it as you can, and you will improve survival. And the reality is, and I have to thank Matthew Katz and colleagues from the ASCO guidelines have essentially adopted the ESPAC clinical trials, even though it's not openly said, but they've actually adopted all the ESPAC trials into the ASCO guidelines. And of course, we now have FOLFIRINOX, but how many can have FOLFIRINOX? There's the toxicity issue. We don't know. Now, this is the Japanese trial called JASAP-05. And what they did, they randomized patients to upfront surgery and S1, or to neoadjuvant gemcitabine and S1, followed by surgery, followed by S1. And this is just an abstract. It's not a published paper yet, but they're claiming better survival for those that had neoadjuvant surgery. But a condition for this trial was that you had to have more patients resected in the neoadjuvant group, otherwise they wouldn't go ahead. Which is absolutely crazy, because the one thing that determines survival is whether or not you have your cancer removed. And this is for so-called resectable pancreas cancer, and yet those that had upfront surgery had less cases resected. That should not happen. It should be 95, 98% across both groups. So there's a problem now. This is the Dutch trial: surgery, GEM, neoadjuvant, GEM radiotherapy, surgery, more GEM. It doesn't work. It is not significant. However much hard you try to tell us, it is not significant. So the primary endpoint was intention to treat. It's not significant. I'm sorry, guys. And one of the big problems with this trial is that if you look at time zero, there is a gap. At time zero, you have events. What are the events? Local recurrence metastasis. And the red is the upfront surgery group. In other words, the upfront surgery group were badly randomized, because at time zero, these points should be exactly at the same point. And the point was they badly randomized patients who have upfront surgery already had metastasis and locally unresectable disease. So there's a problem with the Dutch in the way they stage their patients. And one of the problems is they do it in many centres, it's not centralised, and it's just a bad trial, and it's negative. End of story. So if you want to see a good trial, go to ASCO, Chicago, ESPAC 5, 90 out of 100 patients accrued, not an easy trial to do, surgery up front, all borderline resectables as defined, GemCap for 2 months, chemoradiotherapy, because we want to test it in this setting as well, and also FOLFIRINOX. So same amount of treatment, restage CT at 6 weeks, and then go into surgery. I can't tell you what the results are, but it'd be worth going to Chicago, because it's a good place to go anyway. So good hot dogs. So now I'm moving on to unresectable. This is the world's largest series. It's not a randomized study. So why show it if it's not randomized? Because everything else I've shown is randomized. But in this setting, we don't have any good randomized studies, so I showed you the world's largest series, which gives you a certain amount of bias. And there you see that the resectability rates vary from 47% to 61%. And by unresectable, I mean unresectable. And of course, you really do need to be able to do special type of surgery to take these cancers out after the neoadjuvant therapy, and needs to be a high volume center. And what do I mean by a high volume center? 60 to 80 resections a month, not a year, a month, and with a respectable mortality rate, as you can see here, 3% out of 11,736 operations performed in less than 20 years. So that's what we mean by high volume. So what are the results? Well, if you don't resect, you don't do so well. If you resect, you do a lot better. And so this median survival here is about 17 months. But we also include within this here 51 patients with low volume metastatic disease. So this is an area that's continuously being pushed. Now, a little bit about metastatic pancreatic cancer. The best treatment we have is FOLFIRINOX, but people still die. And there's an awful lot of biology going on at the moment, which tells us a tremendous amount of pancreas cancer from initiation to metastasis, and the potential to use targeted therapies in 30% of pancreas cancer. So it's claimed. Well, this is the reality. Know your tumor. We've heard from the PanCan network the importance of know your tumor. 1,856 patients tested for genetic mutations. 46, 2.5%, actually had treatment with matched treatment. And this is what you call selection. Of course, they did better. And I'm very pleased for these patients who did better. Obviously, we would be, wouldn't we? But the reality is that they also had chemotherapy, and the authors themselves concluded it's difficult to definitively determine the benefits of the matched therapy. So we don't know if it's any good. And we don't know what the median survival rate. We don't know. Why don't we know? Because it's not controlled. Where's Peter Allen? It's not a trial. For a trial, you need controls. There are no controls, so you don't know if it's working or not. So what drugs are actually approved by the FDA for pancreatic cancer? Well, actually very, very few. 4 or 5. And of these, the actual indications are very, very small, 1%, 2%. And the survival benefit is hardly known, and we're talking months rather than years. However, there's a tremendous amount of really great science going into these, and we know this is the way to go. But it's got to be done in the right kind of way. We can't throw out our standard best approaches of surgery and cytotoxic therapy for that. So this takes us on to ESPAC 6 and 7. chief investigator to both, is actually my friend and colleague, Professor Buchlow. So this is FOLFIRINOX, this is gemcitabine, capecitabine. Actually, different groups of patients respond to these cytotoxic regimens differently. So if you say, I'll give everyone FOLFIRINOX, yeah, you can, but half do well, but the other half die. That's not good, is it? So we think these other half probably respond a lot better to gemcitabine and capecitabine. And there's a lot of good evidence for that. And if you were to select the patients properly, you could probably push up, using a treatment-specific signature, push up the 5-year survival rate from, say, 50% to maybe 70%. And there's an awful lot of work to be derived from using organoids. These are where you take pancreas cancer tissue and you grow these as three-dimensional organoids, and they're much, much more representative of what goes on in the real world. And this is Dave Tuvison from Cold Spring Harbor, and he's taken a whole load of organoids, and he's tested them with these familiar drugs that we've got here, and he's got a signature that represents. This is a transcriptomic signature, RNA expression, gemcitabine, paclitaxel, Abraxane, SN38, irinotecan, 5-FU, oxaliplatin. So you can see that each drug has a particular transcriptomic signature. And so if you put this on an expression heat map, this is what you get. And this is actually taking patient tissue from the COMPASS trial that Steve Gallinger has spoken to already about, and you can see that that signature is reproduced. So this then leads us on to a trial design that combines transcriptomic signatures, standard treatment FOLFIRINOX, treatment in the experimental arm, either FOLFIRINOX or GemCap based on that RNA signature, disease-free survival, and if you get recurrence, as you will do, you can then test your targeted therapy, but you have a control group. And similarly, in the unresectable setting, again, it may be that some patients respond better to FOLFIRINOX than to selection with FOLFIRINOX or gemcitabine to enable more resections to take place. So this is a randomized study comparing two different approaches to whether or not you can resect, because it's resection that counts in terms of survival. And again, we can go into palliative, first-line palliative chemotherapy using targeted therapies. So lots of centers in Germany have signed up to this. Peter Bailey, who did the Bailey classification, will be helping to lead a lot of that translational work. And I'd like to acknowledge all these people that have contributed to the development of this multi-modality therapy approach in the past, the present, and going into the future. So thank you.